responsible for that still. All the pharmaceuticals, not responsible for that. All those drugs that are purchased. And provincial programs, which vary from province to province. Cancer is often excluded, ambulance services and so on. So what happened in Canada? We regionalized across the country. Okay? BC started in '96. We went from, I think we had 85 or 90 hospitals at that point. They were all sort of disappeared as entities. And we had 11 regional boards and 34 community health councils, only in BC approach. Just a fascinating period of time. That collapsed completely after 5 or 6 years. And by 2002, we were down to 6 authorities for BC. So some of you, who works for the Fraser Health Authority? I hear it's or Interior. Fraser Health, Interior Health. We have 6 at the moment. Okay? Alberta in '94 started with 17. Made a change in '02, down to 9. Amalgamated, consolidated. Huge change in 2008, 1. One health authority for the entire province of 4.5 million people. Where everyone's watching and waiting to see how this goes. Saskatchewan started in '93 with 32, cut it down to 12. They still have 12. Now, Saskatchewan's a population of, I think, under 1 million people. They have 12 authorities.
That's a lot. I don't know how many, but I do know we have a lot.
Yeah, and some of them are responsible for maybe 50,000 people. Okay, so they have their own organization structure looking after 50,000. Saskatchewan would be right for maybe 2, possibly 1. Manitoba, 11. Still 11, although there's probably going to be down to maybe 2 before long. Winnipeg being 1, and Brandon area being another. At least in discussions. Good old Ontario is still independent, and in '06 they created what they call LHINs, Local Health Integration Networks. Now, provincial money flows to the LHINs, and then it flows from the LHINs to the hospitals. But the hospitals are still independent organizations. Their own CEOs, their own boards, their own directors of finance, their own directors of materials management, and so on. Ontario still hasn't decided regionalization is the way to go. The rest of the province are all regionalized in various ways. Prince Edward Island in '05 wiped out all the regions. They had 4, and now everyone works for the Department of Health. There is no region. It's the Department of Health, the Ministry of Health of the province runs everything. And Newfoundland apparently is talking of reducing their regions some more too. Anyways, there's a lot more detail on other aspects, like there's a whole bunch of slides about the procedures in a hospital. Those who would like to get a better feel of how a patient flows through a hospital. Okay, there's a bunch of slides on that, as well as a lot more on financing and whatnot.
Where's shared services going to fit into all of this? Because right now, Lower Mainland consolidation, basically, we almost feel like we're one healthcare authority for the shared services.
Yep, you are more or less for shared service, right? Provincial health service authority.
PHSA, Vancouver Coastal,
And is Fraser part of that now? Or shared services?
Providence, Fraser.
Well, Province is not an authority.
Well, they're under Vancouver
They're under
Coastal.
Vancouver, they're not authority. Evolving model, you know, as to whether we're going to see a possibility in BC that we might reduce the number of regions. And it's possible that there will be an organization set up, a shared services organization that supports all the regions as a separate organization. You know, it's hard to tell. Yeah.
Is there evidence that going one way or the other is more cost effective, having fewer regions or more regions?
Not that I've seen yet. Not that I've seen yet. Okay. There's no doubt that they reduced a whack of administration costs when they went to region. I mean, if you have 85 directors of finance and their staff, and now you have 1, There's a huge reduction in that, okay? But there's other,
Yeah,
there's
I was
other,
going to say
yeah,
the same
there's
thing.
other aspects,
From
okay?
a political point of view, that argument's often made, but that, I'm not sure that that's actually more, I mean, there are cost savings from those people.
Yeah.
But does that actually get transferred into overall cost savings?
I haven't seen any particular studies, but I'm also not looking for them,
Right.
okay? So I'm not sort of staying on top of that particular agenda.
Two comments. One, the non-clinical services like I think purchasing and IT and
Yeah.
healthcare already on BC to be shared service.
Yeah, sure,
Yeah.
that's what Robin's referring to.
And versus like the one authority with Alberta, and correct me if I'm wrong, but their geographic distributions are much different than ours. We're here, like I work in the interior, what we have in recruitings for healthcare is still fairly different than what we have in Kelowna and Kamloops. And First Nations is just a whole other thing on top of that.
I imagine the same applies to Alberta. I imagine the same applies to Alberta, can't be that different, okay? This hasn't been my thought about it. Okay, I'm gonna shut her down because we're already past the first break, so let's have a quick 15-minute break, stretch your legs, get something to drink and whatnot, and then we will reconvene in 15 minutes, okay? So that's just after 3. Again, for those of you who have sat through this, I think we talked about this last year. Did we talk about this? This is almost part of the orientation from this morning, to give you a sense as to what this field of health informatics is all about, so that you get a grasp of where those of us who are teaching are coming from, where your colleagues might be coming from. Our field, in some ways, was sort of first defined by a German in 1973, who I think he was the first to coin the term medical informatics. It was in German, of course, medical informatique, but when it's translated, it came out with this analysis, okay? And he sort of started things off from the point of view of a field of medical informatics. Morris Collin was the first American to actually also define medical informatics, and he again reinforced the earlier definition that it relates to all fields of medicine. Okay? I was one of the first to coin the term health informatics, and not because I was brilliant or anything like that. I just happened to see a need to make a distinction between what was being referred to until that point as strictly medical informatics to health informatics, to bring in a broader agenda than just medicine, and bring in the broader aspects of healthcare. We see now that Wikipedia, more recently, when you type in health informatics, says it pools the two of them, and it says it's an intersection of information science, medicine, and healthcare. Information science, of course, is the jurisdiction of the librarians. We have a librarian here, don't we? Who's the librarian? So the Journal of Information Science is a library journal. Library science and library information science is a well-established field of its own. So when I inherited health information science, when I came here to start the school in '81, that term, health information science, had been picked already. And we went through a number of iterations over the next 25 years. I think we did it 3 or 4 times where we looked seriously at changing the name of the school from health information science, and chose each time, for a variety of reasons, not to. And I think our new director, Abdul, is going to probably take the school through another iteration and look at whether that's the term we want to continue to be referred to. Michael Humber has got an interesting homepage, an interesting website, and he makes the same reference. Medical informatics and health informatics are variously defined, and he is of the view that health informatics is gradually taking over as the more common term. And health informatics definitely is used now globally more than it used to be back in the 80s. So the distinction, and it's not that critical a distinction, but it is a distinction that I think is worthy of being made, is that health informatics the way we see it is covers the full spectrum of healthcare and all the facets of healthcare, which includes administration, includes government databases, includes planning, research, all aspects of health information from the full interaction of healthcare. Whereas medical informatics is rooted in medicine, okay? And its roots are in medicine and it's still found firmly established in medicine. It tends to focus around supporting clinicians, particularly supporting physicians, okay? It's a critically important field. It's the field that we need to develop that domain, okay? But it tends not to be as concerned with other aspects, such as the sociological, psychological, and a variety of other aspects that health informatics is concerned about. Now, one of the things we struggle with internationally is that the term medicine in Europe, medical in particular, carries a slightly different connotation than it does here in North America. In North America, the term medical pretty well exclusively relates to physicians and medicine. Okay? Whereas medical in parts of Europe is seen as a broader healthcare term, which will encompass others outside of medicine. Okay? So it's a bit of a struggle we have internationally. Bodies of knowledge, historically, it sort of got us started as a discipline, and we are a young discipline. You saw the first definition. Our first international conference was in 1974. Sorry, we had one earlier than that, 74 was the same. It was based on these things. So it started with the medical sciences, the hard sciences of biology and chemistry, engineering, math and physics, and then started to expand, particularly when we started looking at the broader health agenda into economics, information science, management science, psychology, and sociology. We, for our own school, consider sort of the domains and the subject areas that we feel we have to cover in our classes, particularly our undergraduate classes, because that's 4 years and a lot more time with the students. That these are the domains that we cover, okay? And we teach subjects in all of these areas to varying degrees, some in more depth than others, okay? The health system, the organizational communication aspects, which is the undergraduate students here will tell you that in all my undergraduate lectures, I don't hesitate to say in my graduate lectures as well. But the graduate students, most of you are probably already aware of this. The single most important skill to be successful in this field are your communication skills. Second to none, communication skills. The ability to work with others, to work in teams, to be able to sell, convince, understand, listen, all those organizational communication skills are the single and most important skill to develop if you don't already have it. Analytic and critical thinking skills, healthcare delivery in all of its facets, of course the information and communications technology portions, as well as how we are integrating technologies into healthcare delivery. Those are the subject areas that we try to cover. This is a colleague from Scotland who has a fascinating, but it's clustered and clouded. I don't expect you to read it here, but you can maybe take a quick look at it. And she talks about the conceptual map of e-health. Okay? E-health is a new phenomenon, which I'll get to in a few minutes. And Claudia's diagram is pretty comprehensive. This one's there only to say that there are other forms of informatics. There are dental informatics, nursing informatics, pharmaceutical informatics, public health informatics, and so on. Consumer health informatics, clinical informatics, okay? All various aspects, and it's an interesting exercise, which I won't put you through, to go into the literature and find definitions for all of these as to how they're defined. Now,
Quick question, how does coach define health informatics?
I can't answer that off the top